Welcome to this short course on diagnostic challenges in odontogenic cysts and tumours. The course will be delivered by myself, Keith Hunter from the University of Sheffield in the United Kingdom, and Elizabeth Billadew from the University of Pittsburgh. Some information regarding CME points, and neither of the presenters have any financial relationships to declare. In part 1, we're going to cover lesions in the immature dentition. Before we start talking about odontogenic lesions, it's important to spend a short period of time revising tooth morphology and the development of teeth. The odontogenic tissues are complex, but largely comprise epithelial components and mesenchymal components. Epithelial components comprise the oral epithelium, which gives rise to the dental lamina and the enamel organ, and mesenchymal components, dental papilla and dental follicle. The periodontal ligament is a mature part of the mesenchymal component of the tooth. After tooth formation is complete, there are a number of elements of the tooth-forming apparatus which may remain, and these epithelial components are seen in the list on the left-hand side, and we'll look at them in detail later. In the photomicrograph on the left, there is oral epithelium, which is giving rise to the strand of epithelium, which is the dental lamina. Small swellings appear in that, which is the enamel organ, and you can see here that's marked as EO with the dental follicle and the dental papilla also marked. As tooth development progresses, the morphology of the crown is set out, and you can see in the advanced photomicrograph on the right-hand side that the cusp tips are in place and hard tissue formation is about to start. The developing tooth goes through a number of morphological stages, including the bud stage, the cap stage, and the bell stage, outlining the shape of the final tooth. Once that is complete, hard tissue formation may proceed with the laying down of enamel matrix and dentine matrix, which then becomes calcified. This proceeds, and then eventually the tooth crown is complete, and the root of the tooth will also be completed. Once tooth formation is complete, the tooth-making apparatus largely disappears, but there are some remnants, particularly of the odontogenic epithelium, which are very relevant to a number of lesions. The remnants of Hartwig's root sheath, which outlines the root shape of the tooth, may give rise to radicular cysts. The reduced enamel epithelium, which covers the crown of the completed tooth, may give rise to dentigerous cysts, and remnants of the dental lamina may give rise to a number of different lesions, which we will talk about throughout this course. On the left-hand side, we see some cell rests of Malassez, which are present within the periodontal ligament of this mature tooth, a small floret of cells which are easily identifiable. The dental lamina rests, they vary quite markedly in their size and shape, as can be seen in the panel on the right-hand side. So this brings us to a number of problems to address. The first of these is, what happens when we find the odontogenic epithelium associated with the tissues surrounding an unerupted tooth? And this is the sort of picture that you may see, fibrous connective tissue with scattered odontogenic rests, and as in this case, there are areas of calcification. These dental lamina rests are common. They are widespread throughout the tissues surrounding unerupted teeth. In our survey of lesions within the department in Sheffield, we noted that dental follicles and dentigerous cysts commonly contained dental lamina rests, dental follicles 44%, and dentigerous cysts 36%. This also, of note, was the fact that this declined once patients got beyond the age of 25 years. These dental lamina rests can be quite extensive. As you can see, this was the most spectacular example that we found in the tooth-forming tissue, and this was surrounding an unerupted maxillary canine tooth. So there are things to remember in that. Fibrous tissues associated with developing teeth, either erupted or unerupted, often contain odontogenic epithelium. Once the patient is over 25 years of age, this does reduce, but it can still be identified. It is important to resist the urge to call it an odontogenic fibroma unless you have either clinical or radiographic evidence that there is a lesion present. In older patients, it may be important to consider a peripheral ameloblastoma and the odontogenic gingival epithelial hamartoma, which are more extensive lesions and will present either with a clinical or radiographical evidence of a lesion. Problem 2, what about the fibrous connective tissue, the myxoid, fibromyxoid tissues associated with an unerupted tooth? Here we have a lesion in this panoramic radiograph associated with an unerupted and displaced mandibular canine tooth. There is an expansion of the space round about the tooth, it is radiolucent. So this is case number 1 coming up now, another different case of an 8-year-old male, this case. Radiograph taken as part of an initial adult orthodontic assessment, and there is a radiolucent lesion associated with the crown of lower left 7 or tooth 31. Here we have a panoramic radiograph. On the left-hand side, you can see that there is this unerupted second molar tooth with an area of expansion associated with the crown. It's useful to compare the other side, and you can see that space is not present on the right-hand side. Here are the tissues that you'll see in the slide that you have from the slide set, fibrous connective tissue, and some epithelium, and we'll look at these in more detail. Here is the fibrous connective tissue component, mature fibrous connective tissue, relatively paucicellular, and some scattered odontogenic rests. The epithelial component comprises odontogenic epithelium with long secretory ameloblasts. You can see here with the reversal of nuclear polarity and a layer of cells immediately associated with them, which we call the stratum intermedium. This is a good example of the tooth-forming apparatus in the epithelium during the secretory phase of enamel formation. So the final diagnosis in this case is of an enlarged dental follicle. We'd say, well, is that really a big deal? Well, in fact, it is. And when you return to this paper, which was published many years ago by Jin Kim and Gary Ellis, you see the potential of overdiagnosis. And there were, in this AFIP retrospective set, overall 20% error for rates associated with unerupted teeth. And myxoid areas were present in a good proportion of these teeth. When you have a look at the misdiagnosis of odontogenic myxoma in this case, which is a very significant overdiagnosis, you can see that was a diagnosis made in about 6% of cases. So it is a very important distinction to make. So remember that clinical information is vital, and knowing the proximity to a tooth is a key piece of information. Using radiology is very important, and remember that radiologists are your friends and can be very helpful in correlation with the histology. And dental lamina rests and other remnants of the enamel organ are also helpful, although you may need to look for these. Problem number 3 is the question of whether a lesion is a hamartoma or a neoplasm, and this is controversial at present. In case number 2 from your slide set, it's a 5-year-old female who has failure of the eruption of upper right C, that's tooth C, and there's mild expansion. Here we have another panoramic radiograph in this case, and you can see a lot of teeth that are developing, but of particular interest is on the right side of the maxilla, where in addition to these unerupted teeth, there is a radiopaque mass. Here is the histology, and you can see that there are a number of areas of very pink material, and then some more purplish, a little more bluish type material throughout this, but we're going to have a look at this at higher power. And you will notice in these areas, when you look at the cellular areas, that we have something very similar to what we've seen earlier in terms of secretory ameloblasts and the supporting remnants of the enamel organ. Immediately to the left of that is a scaly type material. It looks like fish scales, that is enamel matrix, and then beyond that is the matrix of dentine. So we have odontogenic epithelium, enamel, and well-formed dentine. And so that means in this case, the final diagnosis is of a compound odontome. Not all of these lesions will be calcified when you come to diagnose them. Here's a lesion on the right side of the maxillary tuberosity, and there's a well-defined radiolucency there with no evidence of calcification at all. And this is the tissue from this case, which you can see soft tissue, fibrous connective tissue, but with extensive amounts of odontogenic epithelium. And then when we look quite hard at this, you can see that there are small areas of inductive change where there is very early dentine formation. So this indicates that in fact this is a lesion which is forming dental hard tissue. And this is currently a very controversial area. In the WHO classification in 2005, this would have been termed an ameloblastic fibrodontome, whereas in the 2017 classification, these lesions have been assigned to developing odontomes. And this is a currently controversial area in the diagnosis and in the classification of these lesions. However, I would say that in my experience that there are some lesions which do form dental hard tissue in this context, which are behaving like neoplasms. And this is a case with a large multilocular radiolucency of the mandible, and in fact this was also forming dental hard tissue, and you can see in this case the well-formed islands of odontogenic epithelium. There's dentine formation, there is enamel matrix formation, and so this is an ameloblastic fibroodontum behaving in a neoplastic manner. So things to remember: lesions containing dental hard tissue can vary widely in their maturity. If it's large, you may have to look hard. And the clinical and radiographic details of the case are almost as important as the histology. As we finish this section, a couple of practice points. Be very cautious in making the diagnosis of a odontogenic tumour or a neoplasm in a patient whose dentition is still developing. Do stop and ask yourself if that is correct. And clinical and radiographic information must be very carefully reviewed before arriving at such a diagnosis.